If participants wouldn't mind typing in the chat box if you can hear me, okay, I'd appreciate it. Thank you.
There we go. All right, testing. Can anyone hear me?
Yes, I can hear you.
Great, thanks.
Good morning, everyone. I'm Mark Weeks on behalf of the Florida Alcohol and Drug Abuse Association. Welcome to today's webinar entitled Injectable Naltrexone Engagement and Retention Best Practices. This webinar is being made available through a collaboration of the Office of the State Courts Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any instructions you have, any questions you may have, as you think of them. The presenter will address questions as time permits. All audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options are posted in the in-chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording, go to www.fata.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that time frame. FATA produces many webinars and workshops through the support of the Office of the Court Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct anyone to an evaluation form on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as part of the registering remains confidential. Statements of credits will be posted within 30 business days after the evaluation closes in the individual personal development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close midnight on Thursday, November the 14th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed health practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. For the first time, if you are certified with the Florida Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrivals and departures of attendance and provides a report upon completion of events. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the webinar and the entire webinar. We are not permitted to provide partial credit. Dr. Joseph Volpicelli has over 30 years of clinical addiction treatment research and clinical experience. Prior to founding the Institute of Addiction Medicine, Dr. Volpicelli was a tenured faculty member of the University of Pennsylvania, where he conducted clinical trials on pharmacological treatments for alcohol, opioid, and cocaine addiction. His research into psychopharmacological of alcohol use led to the discovery that naltrexone, an opioid blocker, was effective in the treatment for alcohol use disorders. He has written 2 books and has more than 100 publications in addiction treatment research. Through his involvement with the Institute, he regularly helps educate clinicians on effective medical and psychological treatments for addictive disorders. And now I'd like to welcome our presenter, Dr. Volpicelli. I will turn the presentation over to you.
Thank you very much. Hope everyone can hear me all right. So I'm here today to discuss the use of Vivitrol, or extended-release naltrexone, as a treatment option for use in opiate addiction, and to provide an overview of recent clinical data and personal observations on its efficacy and safety. In today's webinar, I'm going to review various medical treatments for opiate use disorders. Most of us are familiar with medications such as methadone, buprenorphine, or Suboxone, but today I will focus on the use of extended-release naltrexone, or Vivitrol. In this webinar, I'll show how extended-release naltrexone differs from other medical treatment and point out some of its advantages and disadvantages. Since an important limitation of any medical treatment is getting patients to start treatment and stay in treatment, I will then describe the psychosocial program we call the BRENDA approach, which is designed to address some of the clinical concerns of the use of, which is designed to help engage and retain patients in treatment. Finally, throughout this webinar, I will address some clinical concerns of the use of Vivitrol and present some clinical cases to help us think about which clinical situations are especially appropriate to recommend the use of extended release naltrexone or Vivitrol. I'm sure it's not news to this audience, but the opioid use disorders represent a serious public health concern. Despite increased funding for treatment, standard detoxification and standalone addiction rehabilitation programs are not very effective. Most patients, perhaps as high as 70% of patients, will relapse within the first 3 months of completing a 28-day rehab. However, the use of medications such as methadone, buprenorphine, and naltrexone can dramatically improve treatment outcomes and offer hope that we can help curb this opioid epidemic. The scope of this problem is daunting. In the United States, there are over 2 million people with opioid use disorder. Most opiate-addicted people are misusing prescription opioids, such as OxyContin, but a significant number, about 650,000, are using heroin. Heroin is especially addictive since it's rapidly acting and produces a powerful euphoria. In more recent years, fentanyl has been added to heroin, and this greatly increases its potency and lethality. Today, it is rare that I see a patient with heroin in their urine who doesn't also have fentanyl in there as well. This deadly combination is a significant contributor to the dramatic rise in opioid overdoses. In 2017, there were over 60,000 overdose deaths, a number that's higher than the annual death rates for AIDS during the height of the AIDS epidemic. Because the epidemic persists, we must do all we can to help patients who are seeking help for opiate addiction treatment. This includes the use of medications to assist in treatment. Despite widespread acceptance that these medications can save lives, the treatment community has been slow to fully integrate the use of medications into treatment. As this figure shows, less than half the outpatients in treatment receive medical-assisted treatment. There are 3 general types of medications used to treat opiate addiction. Most of us are familiar with methadone, which is given as a daily oral solution in specialized clinics. Another popular medication is sublingual buprenorphine or Suboxone, which is prescribed in doctors' offices by healthcare providers who've been given a special DEA waiver to write for the medication. Finally, there is the less widely known medication Vivitrol or extended release naltrexone, which is an injectable form of naltrexone that lasts in the body for about a month. Vivitrol works very differently from methadone and buprenorphine. I'd like to highlight these differences and offer some insights where Vivitrol can be especially helpful for some patients. There are 3 distinct types of medications used to treat opiate addiction: opiate agonists, partial agonists, and antagonist therapies. It's unusual in medicine that a disorder can be effectively treated by medications that have such different, even opposite mechanisms of action. This slide points out how these medications differ. An important difference is that both methadone and buprenorphine activate opiate receptors, and that's what gives them their special properties. For example, this allows them to relieve withdrawal symptoms. However, it also leads these medicines to cause physical dependence. As such, methadone and buprenorphine must be prescribed in either certified ambulatory settings. A physician or healthcare professional that's prescribing buprenorphine needs a special DEA waiver. On On the other hand, these medicines can be used to help people who have not undergone withdrawal yet and detoxification, and it can help relieve withdrawal symptoms. Buprenorphine and methadone can also have a potential for abuse and diversion, and naltrexone doesn't. So naltrexone does not have any withdrawal symptoms when you stop taking it, and it does not lead to any physical dependence. As such, there are a wide variety of options we can use to treat opiate addiction, because pharmacotherapy should always be customized to unique needs and preferences of the patient. It is important for us to be familiar with all the medical treatments for opiate dependence so we can offer patients these options. Again, today's webinar will focus on the use of the opioid antagonist naltrexone. Naltrexone is available as an oral pill or an extended-release injection known as Vivitrol. While oral naltrexone has been available for decades to treat opiate addiction, it was not particularly effective in clinical practice because of poor patient adherence. Patients simply did not take the medication regularly. This led to the development of a long-acting injectable form of naltrexone, in which naltrexone molecules are coated with a dissolvable substance that slowly releases naltrexone into the bloodstream. This way, Vivitrol is delivered as an intramuscular gluteal injection, and it's delivered every 4 weeks. Vivitrol is non-addictive, non-narcotic, has no known abuse potential, and is not associated with diversion. Vivitrol is widely recognized by leading organizations in addiction medicine as being safe and effective. It is the only pharmacotherapy approved by the FDA for the prevention of relapse to opiate dependence following opioid detoxification. Let's review some of the advantages and disadvantages of Vivitrol. First, its advantages include the fact that there's no abuse or diversion. It does not stimulate opiate receptors, does not produce a high, no abuse or diversion. Number two, it's not a controlled substance. There's no limits in prescribing. There's no special numbers of folks that you're allowed to prescribe it for. You can prescribe it for as many people as you like. There's no special training to get a DEA waiver, so it can be prescribed by any healthcare professional. There's no physical dependence or withdrawal to Vivitrol. And there's substantial data that it works to reduce opiate craving and opioid relapse. Vivitrol also has certain disadvantages. For example, it's not effective in reducing withdrawal symptoms. In fact, it can precipitate withdrawal in someone who's dependent on opioids. It can make withdrawal worse. To avoid precipitated withdrawal, one must be off opioids for several days, at least several days. It's recommended between 7 and 10 days. Number three, it's not as easy to order Vivitrol. It needs to be ordered through specialty pharmacies. And four, the cost of Vivitrol is more expensive than other medications, especially methadone. And it requires the added work in terms of having it to be administered by an injection. So how does Vivitrol compare to buprenorphine in the heads-up trial? A recent head-to-head study compared buprenorphine with extended-release naltrexone, and it was called the XPOT study. In this study, it was a 6-month multi-centered study comparing subjects who were selected for either Vivitrol or buprenorphine treatment. To start the study, subjects had to be opioid-free to receive Vivitrol, or to be successfully induced into buprenorphine. It turned out that it was more difficult to get people to start treatment with Vivitrol than buprenorphine. Of the 283 subjects assigned to the Vivitrol group, only 204, or 72%, received the first injection. Of the 287 subjects assigned to the buprenorphine group, 270, or 94%, were inducted into starting buprenorphine treatment. There's a clear advantage for buprenorphine in getting people initiated into treatment. But what happened once people were initiated into treatment? So for subjects who began the study, where they completed buprenorphine induction or received at least one Vivitrol shot, there were no differences between Vivitrol and buprenorphine in terms of relapse rates or treatment retention. For Vivitrol subjects, 96 of the 204 subjects, or 47%, remained active in treatment at 6 months. For buprenorphine subjects, 115 of 270, or 43%, remained active in treatment at 6 months. This slide shows the incidence of side effects in the extended-release naltrexone group and the buprenorphine group. And in general, this slide shows that there's no differences between extended-release naltrexone and buprenorphine in terms of serious side effects. Now, there are a couple exceptions. For example, injection site reactions, of course, were more common in the extended-release naltrexone group. Most of these site reactions were of minor to moderate severity. There's no differences in terms of cardiovascular symptoms, psychiatric disorders, injury, poisoning, procedural complications, or infections. Now, I do want to point out that some people believe that Vivitrol makes it more likely that one will overdose, especially if you stop treatment. So it's really important to look at that in the study. And it turns out that there were 10 overdose events in the extended-release naltrexone group compared to 9 in the buprenorphine group. And of course, that difference is not significant. In terms of fatal overdose events, there were 2 in the extended-release naltrexone group and 3 in the buprenorphine group. These fatal overdoses occurred in participants who had stopped their study medication. So in general, both medications generally safe and effective, and there's really no differences between the 2 groups, and especially the concern over the myth that naltrexone can increase the risk of overdose. One of the secondary endpoints in the XBOX study was looking at opioid craving. And in this study, opioid craving was measured with a self-reported visual analog scale, in which participants rated from 0 to 100 how strong their craving was. As we can see in this slide, craving was initially high for both groups, and over the course of the study was dramatically lower. So it went from about a 70 on a 0 to 100 scale down to about a 10. So for both groups, craving was significantly decreased. But what's interesting about this slide is that for weeks 2 through 16, craving was actually less for the Vivitrol patients compared to the buprenorphine patients, suggesting that Vivitrol reduces craving more effectively and faster than buprenorphine. And so what can we conclude from the XBOX study? First, it's easier to initiate treatment with buprenorphine than Vivitrol, than extended-release naltrexone. That's clear from the data. It's harder to get people off opiates completely to get the first Vivitrol shot. Secondly, once treatment is initiated, both extended-release naltrexone and buprenorphine were safe and effective in reducing drug use and craving. And I also want to point out something that when you look at this study, even in this well-controlled clinical study, less than half the subjects who started in treatment were still in treatment at 6 months. So even in a well-controlled study, half the people wind up dropping out of treatment within the first 6 months. And that raises the point that in research studies or clinical practice, treatment retention is a very critical issue. And for a medication to be effective in patients, they must take their medication. They must adhere to treatment. In the Xbox study, we saw that treatment retention was about 50% at 6 months, and that seems to be the general trend in most research trials. But what about real-world clinical practice? And in this slide, which is taken from data that's in press from Saxon, we found that in real-life clinical settings, among patients who received the first Vivitrol injection, only about 75% received the second injection. And by 6 months, less than 25% are still getting the injection. The relative low rates of treatment retention is a serious limitation for extended-release naltrexone for opioid addiction treatment. Remember, the reason we developed the injectable form of naltrexone was because the treatment adherence with the oral pill was terrible. And so work needs to be done to increase treatment retention. Now, I have to point out that treatment retention for buprenorphine is not much better. I've looked at data, looking at claims data, and I found that about a third of patients who are taking buprenorphine drop out of treatment within the first couple of months of treatment. And another third show a pattern of taking the medicine irregularly. They go on the medicine, then they stop the medicine, then they go back on the medicine. And only a third, maybe less than a third, are actually taking the buprenorphine consistently over the course of treatment. So the problem of non-adherence led me to design a new treatment program that incorporated the use of psychosocial support in medical treatments for opiate addiction to help increase treatment retention. Specifically, I was looking for a type of psychosocial support that would help engage patients to start treatment, to help improve treatment adherence and retention. And also, since addiction treatment is more than just using drugs or not using drugs, it's about returning to a healthy lifestyle, I wanted a psychosocial support designed to help improve psychosocial functioning. And to improve retention, I came up with the BRENDA approach. And this psychosocial approach I designed to be integrated into medication treatment. And I designed a clinical program using this approach. And this approach I also used in clinical trials, particularly clinical trials that I conducted at the University of Pennsylvania. And in research trials, it certainly is important that to test if a medicine is going to be effective, you have to have good adherence with taking the medicine. And so with my colleagues at Penn, we developed the BRENDA approach. And it came from research data that showed that motivational interviewing was a useful technique to get people to engage in treatment and stay in treatment. And we wanted the motivational interviewing to be fully integrated with use of medications, and for it to be a relatively simple approach that could be administered by a variety of healthcare providers. So we wanted our research techs to be able to use the approach. We're hoping that the approach could be conducted by people who were not PhD psychologists, as the people who are trained in motivational interviewing often are. And we called the psychosocial support the BRENDA approach, because that outlines the steps that we take to help engage people in treatment. And the BRENDA approach has been subsequently used in many research studies, and I'll present some of the data to show its effectiveness. I do want to point out that one of the studies that used the BRENDA approach was the pivotal clinical study that showed that Vivitrol was safe and effective to treat alcohol addiction. So I worked for Alkermes and helped train the clinicians to use the BRENDA approach in that clinical trial. And in that study, we found that 130 of 205 subjects, or 63%, stayed in treatment for 6 months. It worked so well in the research trials, we decided to incorporate the BRENDA approach with Vivitrol in a real-world clinical program to see if it could improve treatment retention. So in 2010, I set up a clinical program that incorporated BRENDA with Vivitrol to treat opiate addiction. Later, I'll present some results from this program, but first I'd like to say a little bit more about the steps of the BRENDA approach. The steps of the BRENDA approach are outlined in this slide. I'll be going over each step in more detail, but I wanted to show an overview of the components of BRENDA. First step is a biopsychosocial evaluation. We follow that up by giving a report to the patient on the results of that assessment. And we do that, as we give the report, we do it in the context of an empathetic understanding of the patient's problem. We want to know how the patient feels about the report that we've just given to them. From the evaluation and an empathetic understanding of how the patient sees the problem, we get a sense of what the patient's needs are, what their goals of treatment are. And those are the things that we try to address in treatment. After we do the BREN part of BRENDA, that's when we give direct advice in terms of how to meet those needs. Now notice, when patients first come into treatment, we don't immediately give them advice of what they should do. And the direct advice is very much directed by what the patient's needs are. And since people are often at different stages of change, we assess their response to direct advice. Some people are ready to take the advice, and other people are still not sure what course they want to go. And so we adjust our treatment recommendations based on the response of the patient to the direct advice. That's the BRENDA approach. So again, the first step of the BRENDA approach is a biopsychosocial evaluation. So while getting a good drug history is important, it's also important to recognize how drug use has impacted one's overall health. And to that end, we conduct a thorough biopsychosocial evaluation at the first visit, and at subsequent visits, we do a follow-up to assess how well the progress that we're making in terms of the biopsychosocial functioning. Biological part of the assessment includes an assessment of drug tolerance and withdrawal. If there have been any overdose incidents, infections, chronic pain issues. Psychological assessment includes evaluation for coexisting psychopathology, particularly for symptoms of mood and anxiety disorders. Social assessment includes reviewing the quality of social interactions the person has with family and friends, how well one is getting along with a romantic partner. It also includes an assessment of a patient's employment status. As we get this data, we help connect the dots for the patient about how their drug use is impacting their life. We put together a profile based on this evaluation, and we present the report to the patient. Now, it's important as we do this, you must stick to the facts. No judgment. So often patients feel defensive if you point out how their drug use is having adverse effects in terms of their functioning. And so we're very careful to present the data in a non-judgmental way. And as we give the report, we're constantly assessing the patient's reaction to the report to get a sense of how the patient feels about what we're presenting to them. Which brings us to the E part of BRENDA, or empathy. It's critically important to listen to the patient's emotional reaction to the report. To give the patient a chance to express their feelings about what we're saying to them. So, for example, someone may say, well, I know my relationship with my spouse has not been going well since I've been starting to use opiates. But that's because we don't get along in general. It's not related to the drug use. It's important not to aggressively present something that seems patently false from our perspective, but to understand how the patient feels about it. It's important not to challenge a patient's reaction, but to understand it. The BRENDA approach is all about collaboration, not confrontation. Which brings us to the next step of the BRENDA approach, needs assessment. The needs of the patient come from an empathetic understanding of the patient's reaction to the report. For example, for one patient, they might be upset because their drug addiction is having bad effects in terms of their social relationships. And that's what's important to them. For another patient, they're more concerned that their body has become physically dependent on drugs or opiates, and they're worried about the withdrawal should they stop using opiates. So for each person, they have a unique concern about how the drug use is impacting them. When you look at the needs, take into account immediate basic health and safety needs. Does the patient have a place to stay? Do they have a stable social environment? Are they going back to a situation where other people are using drugs? Does a patient have a risk of an HIV infection by using dirty needles? Is a patient psychiatrically stable? Patient suicidal? The patient having psychotic symptoms? All these things would necessitate an immediate referral for additional care. But once we understand that the basic needs and safety of the patient is assured, then we are engaged in a process of collaboration with the patient to try to find what the patient's goals and priorities are, to help them understand the negative consequences of their drug use, to understand why they would want to give up drugs. It's important to look at a patient's history of how adherent they were to taking recommendations in the past. Is the patient likely to engage in treatment, to adhere to treatment recommendations? It's important to keep in mind the needs assessment comes from a collaboration between the clinician and the patient. It's not the clinician dictating to the patient what they should do. It's a collaboration between what the patient likes and what we as clinicians feel is a reasonable course for that patient. It answers the question why this particular patient wants treatment. We need to find the hook for why that person wants treatment. Once we find why the person wants treatment, then we can give direct advice that's tailored to the patient's needs. It's important that we explain the importance of medication adherence. It's important that we collaborate in identifying high-risk situations. We point out options to help the patients achieve their priorities. If you think about it, this just makes natural sense. If a person has a need for avoiding withdrawal symptoms, you probably don't want to say you should give up drugs because it's affecting your relationship. If a person's concerned about their social relationships, it's important not to focus on medical concerns that are not their priority. But when you give a direct advice, when you give a recommendation based on what the patient's needs, the person is much more likely to engage in treatment. I mean, even car salesmen know this. If a person's coming into a car dealership looking for a car that has good gas mileage, the dealer probably won't stress how attractive the car looks. And vice versa, if a person's coming in and looking for a fast car, the dealer probably doesn't stress how good the gas mileage is. You want to tailor the recommendation to the needs of the patient, and that's how you engage people in treatment. But even after you give direct advice, even after you give your treatment recommendations, your job's not over. Because people are at different stages of accepting direct advice. Some people are at a stage where they're happy to hear what you say and happy to engage in your recommendations. But in the addiction field, we know not everyone is at that step. Some people say, well, wait till people reach rock bottom, and then they'll be motivated to make change. But I think as clinicians, we have a more important responsibility to help move people along their stages of change. And so as you give direct advice, it's important to get a sense of where the person is in terms of accepting the advice. And sometimes when we give direct advice and people are not interested in taking the advice, it's because we've missed what's important for that person. We've missed something important about what the person is looking for in treatment. So again, it's not about confrontation. It's not about dictating to the patient what they should do. It's about working with the patient where they are in treatment and getting them to move closer to a healthy lifestyle. And we do that by linking the person's actions, drug use, and consequences. And when patients are using drugs and have adverse consequences, we point that out in a non-judgmental way. But we also point out when they're adherent with treatment recommendations, when they're doing the right thing, how their life improves. And we give people social support and encouragement when we see those things. And that helps people stay in treatment, to get those pats on the back. Well, does BRENDA work? There's considerable empirical support that the BRENDA approach works. And it's logical that it would work, since there's a large literature that motivational interviewing is very helpful for getting people to engage in treatment and stay in treatment. And basically, we took BRENDA from many of the steps of motivational interviewing. But what we're encouraged is that we can train folks to use BRENDA who don't have any specialized training in therapy. We've used it to train research assistants, medical assistants. I've used it to train nurse practitioners, physician assistants, physicians, a whole range of folks. And interestingly to me, sometimes the easiest folks to train are those folks who don't have much clinical experience with treating addictions. Now I want to show you an overview of what the BRENDA approach looks like in research settings. So in a study conducted by Osland in 2008, we compared individuals who received BRENDA from a research assistant, again, no specialized training in therapy, to subjects who received cognitive behavior therapy from a licensed cognitive behavior therapist. And we looked at good medication adherence. And in this study, we defined it as, this is using oral naltrexone. What percent of folks took the naltrexone on 80% of the days during the first 6 months of the research trial? And we found that in the CBT condition, in the research CBT condition, about 45% showed good adherence, which is not bad. But in the BRENDA condition, we had 56% show good adherence. Now, the difference there is barely statistically significant, but the important thing is that the BRENDA approach was conducted by people who did not have any specialized training in therapy. Now, how does the data compare with giving people oral naltrexone in clinical practice? Well, Kranzler looked at data for patients who have private insurance, and he found that if you look at good medication adherence, only about 14% of patients showed good medication adherence. So again, there's a difference between what we find in the research setting and what we find in clinical practice. And that clinical practice result is very discouraging. This slide shows what happens when we incorporate the BRENDA approach in a primary care setting for patients who've completed 1 month of buprenorphine treatment. So for patients who received, who are on buprenorphine for a month, what percent were still active in treatment 6 months later? And this result shows that about 60% are still in treatment 6 months later. But when we add BRENDA to that, we find that treatment retention increases to over 80%. So this is real-world clinical setting, and for buprenorphine treatment, for people who complete 1 month of treatment, we can get 85% retention at 6 months using the BRENDA approach. And now I'd like to describe a program that we set up in which we integrated BRENDA with our clinical program. And so in 2010, I set up a clinical program, a real-life clinical treatment program, in which we integrated BRENDA with the use of medications to treat addictions. The question I had is, could we improve treatment retention for patients who receive extended-release naltrexone? And this slide describes the clinical program that we use. When the patients first come in for treatment, we conduct an initial psychosocial assessment. And from that assessment, we go through our BRENDA steps and make a treatment recommendation. For some patients who are still dependent on opiates, we conduct an ambulatory detoxification where people come in every day. Now, some of the folks who are interested in buprenorphine, we think that where that's an appropriate treatment, we'll do a buprenorphine induction, which generally takes a day or two. But for patients who want to completely get off of opiates, we have a protocol that we use to help detoxify people. The protocol that we use, we'll save that for a different day to describe that. But we actually have pretty decent results getting people off of opiates onto naltrexone. But that's not always easily conducted in outpatient practice. But again, that's a lecture for another day. Following detoxification, we conduct weekly psychosocial sessions using the BRENDA approach, and we do that weekly for the first 3 months of treatment. After 3 months of treatment, the BRENDA sessions are reduced to 2 times per month. And then after 3 months, BRENDA sessions are down to once a month for the next 6 months. So notice it's a 1-year program. So in addition to BRENDA, patients receive a monthly medication check, and they receive the extended release naltrexone injection from a physician, physician assistant, or nurse practitioner. At each visit, patients come in and fill out self-report forms that measure craving, cognitive functioning, emotional distress, and we also ask them about current drug use, and besides opiate use, if they're using any other drugs and alcohol. What I'd like to do is present the results of our program over the past 8 years or so. So on this slide, we look at persistence on naltrexone, extended release naltrexone, in patients who are addicted to either opiates or alcohol. And in this slide, we have 161 patients who are addicted to opiates compared to 49 patients who are addicted to alcohol. And what we found was that there were really no differences between the two groups. But what we found was remarkable. Of patients who received 1 shot, about 80% of them went on to receive the second shot. And then over the course of the next 5 months of treatment, out to month 6, fully 60% were still getting the injection. So these are results that are very similar to what we found in the research setting. So we're able to integrate what we learned from research into a real-life clinical setting and get similar results. And that's true for opiate addiction as well as alcohol addiction. We also compared males and females, and we found again that there were relatively little differences between these two groups. We had 142 males in our program, and they showed results which are pretty much identical to females, and we had 68 females in our research. And again, over 60%, around 60% are still getting injections in month 6. And I have to point out something here when we're comparing apples to apples. The other day I was looking at results from a high-priced rehabilitation program in which they said that they conduct research to look at how well their patients are doing after they leave treatment. And so they have a quote, research wing where they call patients. And they reported that, at 1 month, 90% of people are doing well, and at 6 months, 80% of people are doing well. Now, my question is, when they present numbers like that, is that 80% of the people that they contacted or 80% of people who participated in their program? Because probably the folks who are not doing well don't return the call. Now, for the data that I'm presenting here, I'm talking about people who actually got the injection. This is needles in the butt data. There's no way to fudge these numbers. And for some of the folks who were not getting injections, they were still in treatment with us. Sometimes they went on to buprenorphine, sometimes they went to oral naltrexone. So the actual results in our clinical program were better than this. But these data represent if you actually got the injection at month 1 through 6. The next slide presents data for naltrexone, extended release naltrexone, in patients involved with the criminal justice system. Now, when we looked at this, we weren't sure if that would help the cause or hurt the cause. So for many of our patients, they come in for treatment, and their motivation is that they're compelled for treatment because they want to avoid reincarceration. And the question is, would those folks have better retention than folks who come in for treatment in general? And so we had 62 patients who were involved with the criminal justice system, were generally on probation, and we compared that with 147 subjects who had no criminal justice concerns, and we found that the results are pretty much identical. If anything, there's a slight higher probability of getting the shot if you're slightly higher for people without criminal justice, but that difference was not significant. So for people who look at our data and say, well, maybe you have a suburban, highly functioning group of folks, I can tell you that the folks that we see in our program are very similar to what you would see in any other program. So besides involvement with the criminal justice system, a high percent of our patients also have psychiatric comorbidity. The concern would be for patients with anxiety, depression, schizophrenia. How would that impact their retention and treatment? So we had 76 of our patients with a concurrent psych diagnosis compared to 132 patients without a psychiatric diagnosis. And again, we found, if anything, patients with a psychiatric diagnosis had a little bit stronger persistence than patients without a psychiatric diagnosis. The psychiatric diagnosis does not predict higher dropout rates. In our program, we have patients, some patients, that can use their private insurance to help pay for treatment. And we had 78 patients like that. So the treatment was not so expensive for them because they could use their insurance. Then we had 132 patients that were fee-for-service patients, so they had to pay out of pocket. And we looked to see how that impacted treatment retention. And what we found is very interesting, that the fee-for-service patients, the people who have to pay for treatment out of pocket, had lower retention than the people who had their treatment paid for by insurance. This difference isn't related to demographic differences between the two groups. Most of our fee-for-service patients were just as employed and had stable social relationships as the folks with insurance. It's just that there's only one insurance company where we accepted their insurance. Now, this is important to keep in mind because as we try to design healthcare, as we're trying to improve treatment outcomes, we want to reduce barriers to treatment for patients. And having to pay for treatment out of pocket is one of those barriers that can have the adverse effect of having worse outcome for patients. And I would maintain that the folks with worse outcomes will increase healthcare expenses because they'll have more emergency room visits and concurrent medical problems that are not being addressed because of their addiction. So sometimes I wonder if removing barriers to treatment will actually save healthcare dollars and have an overall beneficial effect in making it difficult to get treatment. Now I want to get to an interesting slide, and this slide needs a little bit of explanation. In our program, we offered Vivitrol injections to any patient that was interested in getting Vivitrol. And some of the programs that surround us would do psychosocial treatment, and they would recommend Vivitrol for their patients, and they used us as a source to give the injections. So, for example, right across the street from us is a IOP program, and we receive their patients and give them Vivitrol shots. But they were not participating in our BRENDA approach. And so for folks who received the full-blown BRENDA, we had 113 folks in that category. We compared their retention with folks who did not receive full BRENDA. And some of them were referrals from other programs. Some of them came to treatment with us, but were not really interested in any of the psychosocial component. And what we find is remarkable. The folks who did not get the full BRENDA, their retention was much worse than the folks who received the BRENDA approach. Of the folks who got one injection, less than 70% wound up getting the second injection. And you can see from this slide, the percent of folks who got subsequent injections was reduced every month. And so by month 6, it was about 40% of people who started with us were still getting injections. Now, compared to other clinical experience, that's probably not too bad of a result. But from my perspective, that's not very good retention. On the other hand, the folks who got the full BRENDA, nearly 80% of them were still in treatment at 6 months. And that's even better than some of our research data. This suggests to us that one could set up a real live clinical program that incorporates the use of Vivitrol, and when combined with the right kind of psychosocial support, it helps patients stay in treatment for 6 months. And although I don't present the data here, many of our patients continued in treatment past 6 months for a year, sometimes even longer. And as this figure shows, that once you make it to month 6, or actually once you make it to like month 3, the number of people who drop out of treatment at that point is very low. We have many folks who've been with us for a while, and I have to say we're having a little bit of a baby boom as our patients are getting their lives together, have improved social relationships, have gotten married, and are now having kids. And from my perspective, it's incredibly rewarding to see the results of our clinical program. And with that, maybe I can take a question or two, and then we can take a break and come back and talk about some clinical situations where extended release naltrexone versus buprenorphine or methadone would be considered.
I've posted a few of the questions that have come up in the chat. You'll find it in the right side corner in the chat there. There's a couple of people asking questions.
Okay, so one question is, do you think that utilizing daily naltrexone after finishing titration of methadone would be the best practice for our clients if I work in a methadone maintenance program? Or is it better to offer naltrexone with psychotherapy by itself? It's a little bit difficult going from methadone to naltrexone, but it's possible to do that. So you want to reduce the methadone gradually over time. But yeah, if people are used to coming in every day, one I guess could use the oral naltrexone. But my recommendation would be, and this is based on the experience using oral naltrexone versus the extended release naltrexone, that it's better to try to get them to the injection. For oral naltrexone, one has to decide every day, do I want to get high? And most days people will say, not today, not today. But sometimes things will happen. Maybe they have a fight with their spouse, maybe they go to a meeting and people are talking about using drugs and it stimulates craving. But over the course of a month, there's maybe a day where their craving gets high enough that they might want to relapse. Now, if you get this shot, you only have to make the decision once a month, I want to be opiate free. Then the rest of the time, it's not an option. And what I find is that once people make the decision to get the Vivitrol shot, it takes it sort of off the board and helps reduce craving to want to use. So if it's a daily buprenorphine or daily naltrexone pill, people still have the option of getting high if they stop their medication for a day or two. And that keeps the notion of using drugs still at the forefront of their mind, and I think increases their craving. So for me, I'd rather use more of the extended release naltrexone than the oral pill. Okay, and in terms of naltrexone with psychotherapy by itself, that's a really interesting question. And I remember when I worked at the VA, I worked with alcohol-dependent patients in Building 4, and then we had Building 15 for the methadone patients. And the idea was we wanted to keep the methadone patients segregated from the patients who were more abstinence-oriented. Now, it was nice that one was alcohol and one was opiates, and so the traditions of those two treatments tended to be philosophically different. But then, when the cocaine epidemic hit, the question is, where should we treat the cocaine-dependent patients? In a abstinence-oriented program or a maintenance program? And the decision was made that the cocaine-dependent folks will come into the alcohol treatment unit where the goal is not to use drugs, not to be on an agonist therapy. So that was the decision. I'm not sure I agree with it. I would prefer to see all options available in one setting with people not having biases that you have to use one versus the other approach, that depending on the needs of the patient, that's help determines your treatment recommendation. Now, when I suggest this to inpatient programs, however, they come back and say, if some folks are getting buprenorphine and other folks are being offered naltrexone, that creates problems among the groups. That the patients who are on Vivitrol wonder why they can't get buprenorphine because they hear how wonderful it is. So it still remains to be seen whether it's overall helpful or not helpful to combine those kinds of treatment options. So that's a really good question. Let's see. Okay, a couple of patients reporting increased depression and suicidal ideation on Vivitrol. Have you seen this in practice? This is something that shows up, I think, on the internet quite a bit, and I believe is a myth. Now, not to contradict your clinical experience, but I'm very careful when I treat folks to assess for psychological distress. And so we have a questionnaire that we give people at every visit. It measures anxiety, measures social sensitivity, it measures suicidal ideation, it measures enjoyment in things. And what I have found is that there's no difference. If anything, there's less psychological distress in the Vivitrol group compared to the buprenorphine group. And I've been conducting research with naltrexone for, 30 years or so. And I was very careful to look to see if naltrexone interferes with people's social experience or enjoyment in things. And I never found evidence to support that. Actually, there's a couple exceptions. For individuals who are on naltrexone, I find that they don't like incredibly hot, spicy food as much as they used to. So this is like Indian hot spicy that's painful, brings tears to your eyes. They don't like it as much when they're on naltrexone. I also found that some of my patients who are sort of ultra marathon runners, not the regular marathon, 26 miles. This is like people who run like 150 miles, or 50-mile marathons, that running wasn't quite as good. I know there's some data in non-addicted populations where they give opiate antagonists to see how it affects social functioning. And there's some slight hint that it reduces the pleasure that you get in social interactions. However, I have not seen any evidence of that in my clinical practice. For example, there's some data that actually opiate antagonists help improve one's sex life. As most of us know, there's nothing to interfere with sex drive than being strung out on opiates. Anyway, by blocking the opioid receptor, that seems to help bring sex drive back. So again, I have not seen any evidence that Vivitrol is associated with increased depression or suicidal ideation. Let's see, any other questions? Any data on Vivitrol with BRENDA in AA and NA meetings? I don't have systematic data on that, but many of the patients who come to see us go to meetings and have no problem at all integrating what we do in our program with going to meetings. Now, it used to be the case that they would sometimes be embarrassed that they were taking a medication to assist them in treatment, but I think that's changing in AA meetings. Now that they understand how Vivitrol doesn't make you high, there's no withdrawal, there's no diversion, many of the folks in AA meetings are actually kind of pro-Vivitrol. They're not so pro-buprenorphine, however. And I'm going to say a little bit more about that after the break, about the differences in philosophy of treatment and how sometimes the AA approach, the abstinence-oriented approach, is more consistent with using Vivitrol than with an opiate agonist. So with that, I think that's the last question. Let's take a short break and come back in 5 minutes or so, and we'll take up the issue of who to recommend buprenorphine for, Vivitrol for, and understanding when's appropriate to do one medicine versus the other.
Yeah, it sounds good. We'll take a 5-minute break here shortly, but there are two other questions.
Oh, I'm sorry.
One up and down from any data on Vivitrol and AA and NA meetings. If you want to address those very quickly, then we'll hit our break.
Okay. So any data on Vivitrol with BRENDA and AA and NA meetings? Yeah, so what I find is that while there's no systematic data on that, I can tell you in my clinical practice that many of my patients who are on Vivitrol and receive BRENDA also go to meetings, and they find that there's no problem with doing the combination of those things. And if anything, it's easier for them to tell the members of the NA group that they're taking Vivitrol than days when they were taking buprenorphine. So, for example, I have some patients who've been on both buprenorphine and Vivitrol and go to meetings, and when they were on buprenorphine, they would often hide the fact that they were taking buprenorphine because that would be frowned upon. But as people understand how naltrexone works, that it doesn't produce a high, there's no euphoria, no diversion, that many of the folks who are in abstinence-oriented programs actually welcome Vivitrol. Okay.
Another one just popped up.
Oh, another one popped up? Let's see. Oops. Oh, okay, so this is in the chat. Let's see.
Yeah.
Were there any weekly sessions, group counseling? Okay. Yeah, so what about group counseling? Well, I would like to do group counseling, but we haven't done it in our program yet. But we just hired someone to start groups. And the way I look at group counseling, and I've designed group counseling type programs for inpatient programs, is I like to use it as a chance to do some psychoeducation. I find that there's people who come into treatment often have various biases and prejudices about what addiction is and how to treat it. Sometimes they come in filled with shame, they come in filled with misconceptions, and so it'd be really helpful to use the group settings to help educate patients about it, and then to give them some time to help process what they've learned. We usually don't use our program to replicate what people can get in 12-step meetings, which can be very helpful. Again, a lot of our patients come in with feelings of shame, and to be in an environment where other people are sharing about their addiction can be really helpful as a way of unburdening themselves of their shame. Now, I have to say, in the old days, that when we talked about naltrexone to treat particularly like alcohol use disorders, that some of the people in meetings would complain to my patients that they should not use a crutch like naltrexone. That attitude seems to be changing. I don't know what your experience is, but there seems to be less of that now as people understand how naltrexone works. How about using telemedicine for individual sessions? I just did that yesterday with a woman who I saw for a couple of years. She was on Vivitrol and then oral naltrexone to treat her alcohol problem, and she did beautifully for a while. Then she wanted to drink socially and fired me, so I didn't see her for a while. And 3 years later, she called back again, and we commute by FaceTime to have our session. So I have several patients that I do FaceTime visits with, or even telephone sessions. So I think this integrates very well with telemedicine. So yeah, I find it hard to get clients to come in for weekly sessions. Yeah. Well,
alrighty. We'll go ahead and set the break for now, and it will rejoin in 5 minutes. However, Mary Coy did, I think her question got overlooked, and we'll answer it after break. I think it's a really good question, actually. So I wanted to jam that in there while we got you. But let's go ahead and reconvene at 11:15 sharp, and thank you.
What's your question?
Hello and welcome back. Dr. Volpicelli, if you're ready, I'll read Mary Coy's very great question aloud to you.
Please.
Is there a time goal to be on Vivitrol and possibility of relapse when done with treatment?
That is a great question. There is not very good research data on how long one should stay on Vivitrol. But I will give you one experiment that I did, and I still haven't reported the results yet. But what in the study, and this is with alcohol-dependent patients, I had them on Vivitrol for 1 month, and another group was on it for 6 months. I'm sorry, one group was on it for 3 months, another group was on it for 6 months. And what I found was that when I stopped the naltrexone after 3 months, that group slowly began to relapse. And so by the end of 6 months, they were using opiates at a rate not too dissimilar to folks who never got to Vivitrol in the first place. So 3 months is too short. I had another group that I kept them on Vivitrol for 9 months and stopped it. And that group looked pretty good even after we stopped the Vivitrol. Now, my recommendation, though, is that once you start Vivitrol, you should be on it for 1 year, and here's my rationale. I like to give people a chance to go through a whole year's worth of holidays and birthdays and everything else where they are abstinent so that they can see how good life can be. For folks who stop after 1 year, a fair percent of them continue to do well past that. But there are some criteria that I look at where I don't recommend that people stop. For example, I have one patient who was on Vivitrol for a year, and he said, okay, I did my year, now I want to stop. But this is someone who, before they started Vivitrol with us, had overdosed and was brought back to life with Narcan. His mother had psychiatric problems, and she overdosed herself and died. And I knew how hard it was to get this person engaged in treatment initially. And for him, I recommended that we stay on Vivitrol. Well, he did not take my recommendation. And a week later, I got a call that he had overdosed again. And unfortunately, was brought back. And now he's back on Vivitrol and he's doing fine. So for some folks, I recommend staying on Vivitrol for longer than a year period. But the usual recommendation is 1 year of treatment. Now, it's been reported in the literature that when someone's been on Vivitrol for a while, if they relapse, they're more likely to overdose. And let me explain that. That if you abstain from opiates for a month or so, you lose tolerance to opiates. So if you go back and use your former dose that you were using, if you're using 6 bags a day, you may not have the same tolerance after you've been off opiates for a while, and that includes being off because you're on Vivitrol. And so a person may accidentally overdose. And so that's the concern that we have. If you're on buprenorphine and you stop that, well, you haven't been off opiates for 6 months. And so you don't have the loss of tolerance that you would have if you're on Vivitrol. And so the theory is that if you stop buprenorphine and you use drugs, you have much of a less chance of overdosing. Well, when we looked at the data, we have not found any differences in risk of overdose between the two groups. And I think part of the reason for that is that Vivitrol, when it leaves your body, it leaves it gradually. So even though they say get a shot every 4 weeks or so, for some people, there's still some Vivitrol, some naltrexone in your body beyond the 4-week period. So it doesn't leave it like all at once. And I think that's why you don't see any increased risk of overdose. But again, that's something that we're looking at carefully. And we have to explain to people that, God forbid, if you should go back to using opiates after you've been abstinent because you've been taking Vivitrol or maybe you're inpatient or whatever, you lose tolerance, and whatever you're using before is more likely to cause an overdose now that you've lost your tolerance. I hope that answered the question. All right. Can we go on to the next slide? Can people still hear me?
We can hear you. Are you moving your slides?
Yeah, here we go. Great. Oh,
Uh-oh.
7. How do we get to 7? Oh.
How did we get here? All right, hold on for just a moment.
Okay.
I don't know why that happened, but I'm seeing your slides now at 33.
Okay. I still have the intermission slide. Let's see. Oops. Nope. Yeah, I don't have my next group of slides. I can try and do it without slides. Oh, here we go. Great.
All right, I've given command back to you.
Perfect.
All right,
Great.
good. Sorry about that.
No problem. So to switch up gears a little bit, I'd like to sort of review what we've learned so far. First, we found that there's a variety of medications that have very different mechanisms that can aid in opiate addiction treatment. And so we can offer a variety of options to patients to help them in their recovery. These medications are safe and effective. Medicines like buprenorphine and medicines such as methadone and buprenorphine and activators stimulate opiate receptors, so they're effective in reducing withdrawal symptoms. And it's easier to initiate treatment with buprenorphine compared to extended release naltrexone. However, once treatment starts, there's not much difference between patients taking buprenorphine and extended release naltrexone. Maybe there's a little less craving with naltrexone. The critical issue for all treatments is how to engage patients in treatment and keep patients in treatment. And what I've shown is that it's possible to design a clinical program that incorporates Vivitrol with psychosocial support to obtain good treatment retention. So the question is, how do we make a rational recommendation over which treatments to use for our patients? Now, much of our recommendations is going to depend on our philosophy in terms of how we look at the nature of addiction. And for the next part of the webinar, I want to sort of challenge our assumptions and thoughts and thinking about how we look at addiction so we can understand the differences in treatment approaches. So most of us are familiar with the DSM-5 definition of addiction. And according to DSM-5, addiction is a complex condition, a brain disease that's manifested by compulsive substance use despite harmful consequences. With addiction, have an intense focus on using certain substances such as alcohol or drugs to the point that it takes over their lives. They keep using alcohol even when they know it will cause problems. After treatments are available and people can recover from addiction and lead normal, productive lives. That's the definition. Now, I want you to look at that and notice that the DSM-5 defines addiction by its consequences. Addiction, what it does to people. Produces compulsive use despite harmful consequences. It takes over their lives. So addiction is defined by its consequences. ASAM has a similar definition. It's a treatable chronic medical condition that involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatments are generally successful, as they are for other chronic diseases. And again, notice how ASAM and DSM-5 defines addiction by its consequences, what it does to people. And the implication here is that addiction is something that's an organic disease, probably in the brain, that leads to bad consequences. And so if you accept these definitions, it makes sense that if you can reduce those bad consequences, then you have effectively treated the addiction. Now, I want to contrast that by sort of our common sense notion of what addiction is. And this old Japanese proverb, I think, sums it up the best. First, the man takes a drink, then the drink takes a drink, then the drink takes the man. And what this slide shows is the self-reinforcing cycle on which taking a drug increases the need to take more of it. That's the essence of addiction. Here's another way of looking at it. The addictive cycle is one in which use of a drug creates the motivation or need to use more of a drug. Taking a drug may temporarily give you some relief, but as the drug wears off, withdrawal symptoms further increase the motivation to use. This is the addictive cycle. And a consequence of this addictive cycle is it begins to take over a person's life, and then leads to adverse consequences. The fundamental property of the addictive cycle is that the drug use creates its own motivation to use more drug. Now, if you accept this model of addiction, it assumes that the way to treat addiction is to break the addictive cycle. So when we can reduce symptoms and consequences, that's fine, but that fundamentally doesn't necessarily break the addictive cycle. So this model of addiction, of understanding of addiction, is a model that lends itself to more of an absence-oriented approach to treatment. Since to treat the addiction, you break the addictive cycle. Now, some people, when they look at drugs, they tend to link them to other things that are rewarding in life, or other needs that we might have. But it's important to differentiate natural rewards from addictive rewards or needs. So we're all born with natural needs such as hunger. These needs are present at birth. And when you engage in behaviors that are motivated by hunger, such as eating, it tends to reduce the motivation. You get full. The behavior takes away the motivation to engage in the behavior. It's a negative feedback loop, homeostasis, if you will. And over time, your hunger doesn't increase as you get older. I have a 1-year-old grandson, and he acts as hungry as his grandfather does when he doesn't eat after a few hours. Doesn't take over your life, because after you eat, then you want to do other things. Natural needs tend to be stable over time. Instead of a self-reinforcing cycle, natural needs have more of a homeostatic cycle, which engage in the behavior, reduces the need to engage in the behavior. Addictive needs, on the other hand, they're not present at birth. No one, is born, well, I won't say no one, but it's rare for someone to be born with a need to take opiates. However, if you use heroin over time, the need to use heroin gets stronger and stronger. So how does this relate to understanding, say, buprenorphine or agonist treatment versus Vivitrol treatment? So buprenorphine works by stimulating opiate receptors. So it takes away withdrawal, but when buprenorphine wears off, the need to stay on an opiate is still present. Now, I've tried to explain this model to patients, and my best analogy that I can think of is buprenorphine is like leasing a car. It gets you transportation, but you still don't own the car until you pay for it when the lease is up. So you don't go through withdrawal when you go on buprenorphine, but you still have to deal with the withdrawal later when you come off of it. Now, some people say maybe you should stay on it indefinitely. Most of my patients, when they start buprenorphine, don't see it as a lifetime commitment. And so when they want to come off of it, they have to pay for the price then. Naltrexone is like buying the car. It's harder in the beginning, takes more effort in the beginning, but once you're on it, there's no withdrawal. You own the car. It breaks the cycle. So if your philosophy is that you believe addiction is a self-reinforcing cycle, which creates the need for more of the drug, then something like naltrexone makes more sense. If, on the other hand, you define addiction by its consequences, then it makes perfect sense to use medicines like buprenorphine or methadone because it helps reduce the consequences. Now, for myself, I'm of two minds on this, and I have many patients who are on buprenorphine and many patients who take naltrexone, but I wanted to point out sort of the philosophical differences between the two approaches to treatment. And this helps me in terms of understanding what recommendations I make to my patients. And so what I like to do now is get your feedback and get your input in terms of how you might approach treatment for some specific clinical examples. So I really want your feedback on this. So the first case is the case of a 26-year-old male returning to an old neighborhood after a 6-month incarceration. Is currently on probation. So the question is, what do you recommend for treatment for this individual? Did he go to abstinence 12-step program? Did he go to a methadone treatment program? Does he go on buprenorphine? Does he do the combination of naltrexone and psychosocial support? What do you think? What would we recommend for that person? When I evaluate a patient, I try to ask myself, what are this person's likely needs? So for a 26-year-old who's returning to his old neighborhood after being opiate-free during prison, the question is, what does he need? Since he's already detoxed, he probably doesn't need a medication to help remove withdrawal symptoms. So that would make it less likely I would recommend a medicine like buprenorphine or methadone. Since he's going back in his old neighborhood, I know the chance of relapse is very high. So I would recommend going on a medication. I would recommend a medication like naltrexone. It helps reduce the craving for opiates, and God forbid if he should slip and use an opiate, the opiate won't have any effect on his brain because his opiate receptors are blocked, and the slip is not likely to lead to a full-blown relapse. In terms of going to meetings and such, if that's something he likes to do, I recommend that he do that. So for someone like this, I'm more likely to recommend the withdrawal psychosocial support as likely to lead to the best outcome and reduce the risk of relapsing. And let's see, so we have some comments here. So some people say 12-step programs. I need to discuss all available options and start with what they felt would work best. Yep, if they were bored, naltrexone makes sense. Naltrexone 12-step, great. Yeah, so, and then again, part of the BRENDA approach is that we give people options, but we also help them with making a informed decision. So when a patient comes in to see their doctor, sometimes people have preconceived notions of what their treatment should look like. For example, they may have heard of buprenorphine, Suboxone, and they've never heard of Vivitrol. So we have a responsibility to help teach them what all the various options are. For someone like this, I probably would be relatively stronger in recommending the naltrexone and AA versus other options, just given his clinical situation. Well, first problem is people, places, and things. Help him find a way to move from his old neighborhood. Substance use counseling with naltrexone support. So again, the AA approach is often the way to help break the cycle is getting the person out of the environment where the drugs are. And that can be effective if someone is able to do that. Unfortunately, some people are not able to do that, and that's where a medicine like Vivitrol can be helpful because, again, even should the person have a split, it's not likely to lead to a full-blown relapse so long as they continue to get the naltrexone. What withdrawal does a person go through when stopping the naltrexone? There's no withdrawal when you stop the naltrexone. Zero, none at all. But thank you for your feedback. This is good. Let's consider another case. So here's the case of a 31-year-old female who's recently overdosed and not interested in treatment at all and is interested in becoming pregnant down the line. What would you recommend for her? Abstinence-oriented program, methadone treatment program, buprenorphine program, or extended release naltrexone and psychosocial support. So again, this is probably not an atypical situation. So what are we going to offer for her? Well, if she's recently overdosed, you want to help prevent the chance of overdosing again. And so abstinence-oriented program by itself doesn't help prevent the overdose. So I probably would recommend some form of medication, probably in conjunction with 12-step if she's willing to go, although from her presentation, it sounds like she's not really interested in going right now. So medication would be helpful. Now, if she's recently overdosed, it sounds like she hasn't completely detoxed yet. So medicines like methadone and buprenorphine may help take away withdrawal symptoms, so that would lean me more toward that. And probably the clincher would be if she wants to become pregnant. There's much more data that methadone is safe to take during pregnancy. Buprenorphine is probably safe to take during pregnancy. And naltrexone, we don't have enough data to know if it's safe to take during pregnancy. Now, there's one caveat here that if she takes methadone or buprenorphine during her pregnancy, her child is likely to be born with neonatal abstinence syndrome, and so that's a risk. But in general, I think most healthcare professionals would recommend being on the medicine during pregnancy to avoid sort of the highs and lows of opiate stimulation from heroin, that would still be safer for the child to go through the controlled neonatal abstinence than to have neonatal abstinence during the pregnancy in utero. Let's see. Is it cost effective? People with low income, does Medicaid pay for it? Great question. Just trying to be prepared for that. And here's our experience. So when we first started using extended release naltrexone, it was relatively hard to get insurance companies to pay for it, and we had to go through elaborate steps to get prior authorization. That has really eased up dramatically. Now, very few private insurance programs will not pay for Vivitrol. I believe Medicaid will pay for Vivitrol, no problem there. Medicare pays for it.
Medicaid pays for it.
Medicaid pays for it.
It's like a $1 copay. They actually prefer it over buprenorphine products. Process is much easier to get it covered. Medicare, still a little hairy there.
So that was Lauren, who works with me, and she's the one who gives most of the Vivitrol shots, and she helps me in terms of ordering Vivitrol. So it sounds like Medicaid, no problem. It's $1 copay, so they couldn't make it any easier. For Medicare, for us folks over 65, it's a little bit harder to get it approved.
And for totally uninsured patients, there are options for that as well, such as a patient assistance program where Alkermes will provide the shot free of cost for that patient if they meet the criteria.
Methadone treatment to reduce risky pregnancy if relapse occurs. Yeah, there's plenty of data to show that methadone during pregnancy helps the woman get through the pregnancy without relapsing. So I think many people would recommend some form of medication to take during the pregnancy. Are there studies of the effect of naltrexone on in utero in the fetus? So there's animal studies, and the animal studies, it's hard to say for sure something is safe. but there's not very much data in animal studies to show that it's not safe. Now, I have to tell you of one example that I have in my clinical practice. And this is a woman who was taking Vivitrol, and at about month 6 or 7,
She told us 1 month.
oh my goodness, at month 8, she came in and informed us she was pregnant. She didn't know that she was pregnant. Now, we probably should have been checking the urine for pregnancy, but this is someone who told us she wasn't having sex with anyone, and we assumed that that was true. And she still, to this day, says she doesn't know how she got pregnant. And since her child was born like December 26th, I think it's an immaculate conception, second time in history that that's happened. But anyway, her child comes to therapy with her, and he's wonderful. So he was on Vivitrol for 8 months, and Leo is incredibly advanced for his age. So he's walking and talking, and it embarrasses me because my 1-year-old grandson is not up to his level. But he's doing great. But that's just one case. To be safe, there's not enough data to show Vivitrol is safe to take during pregnancy. Okay. Understand Medicaid is state by state. Yes, so you have to look at Medicaid in your particular state to see what they're going to pay for. Methadone has an advantage of being incredibly cheap in any state. And so that's an option for people who can't afford other medical treatments. What about the average out-of-pocket cost? So for private insurance, often there's a copay for Vivitrol. Now, the good news is the company that makes Vivitrol will give people a rebate for their copays. So typically, people who get on Vivitrol don't have to pay anything out of pocket. Did your child experience any withdrawal after birth? No. Excuse me. All right, can you take the next one?
Okay, so for our next slide, we have a 55-year-old female who has just completed her 3rd rehab in the past 5 years and is tired of the revolving door. So again, we have the same options for this case: abstinence 12-step program, a methadone treatment program, buprenorphine program, or an extended release naltrexone and psychosocial support program.
So what do you recommend for this patient? So this is someone who has, has a high chance of relapse, 3rd rehab. She's getting tired of going back into rehab all the time. And apparently she's been clean for a period of time because she's just been in the rehab. Certainly going to 12-step meetings can't hurt. I probably would not put her on methadone or buprenorphine since she's already clean. For her, I would probably recommend naltrexone and psychosocial support. Yeah, so abstinence 12-step with extended release naltrexone and psychosocial support. I agree with that. That's what I would recommend for that person.
And I think in cases like this, it's helpful, the 12-step programs for people to really get that camaraderie and to meet other people who have similar situations to them. So in addition to doing the medication and the psychosocial support within a professional office, it also helps to have the peer support, which you really get from a 12-step group.
Lauren, can you take over the next one?
So we have a 45-year-old male who's been taking street buprenorphine and now wants a prescription. So again, we have the same options of an abstinence 12-step program, a methadone treatment program, a buprenorphine program, or an extended release naltrexone and psychosocial support program. So again, it sounds like this is a man who has been taking illicit buprenorphine, meaning he's getting it off the street instead of using illicit opioids such as Percocet or heroin. and now he has decided to seek a professional to continue this medication. We'll wait for comments to see what you guys think. So Stamatina says, continue buprenorphine, but rather in a clinical setting. Agree definitely with that. So Robert says, abstinence program, then bute program to get him off, then extended release naltrexone treatment. That makes sense. So that would be an option to stabilize him in a professional setting. And then down the road, think about switching him to extended release naltrexone. And then Amy says naltrexone and psychosocial. So I think all of those make sense. Dr. Volpicelli, do you think that you would continue him in a professional setting with buprenorphine until you sort of understand what his needs are and see what direction you'd like to go?
Exactly, yeah. So I would probably continue him on buprenorphine and then talk to him. And we've done this in our clinical practice many times where we start someone on buprenorphine and help them get stable. And then as their lives get stable, we transfer them over to extended release naltrexone. And that probably would be my recommendation for this individual. So do we have any other cases? Oh, okay. So I wanted to conclude and then have some period of time where I can answer other questions that you might have. And so what did we learn? That extended release naltrexone may be more difficult than other medications to start patients in treatment. People have to be clean, off opiates before you can get the first shot. But for people who have successfully detoxed from opiates, it is a safe and effective treatment. Agonist medications such as methadone and buprenorphine are effective in reducing harm, the harm associated with addiction, but still one remains physically dependent on opiates when you're on agonist therapy. Finally, extended release naltrexone combined with psychosocial support can lead to breaking the addictive cycle in a large percentage of patients. And with that, I'll take any questions you have.
Are there any, so Amy asks, are there any withdrawals when switching a patient over from buprenorphine to naltrexone?
So Amy, that's true. There will be withdrawals. That if you start the naltrexone too soon after someone's been on buprenorphine, you'll precipitate withdrawal. And so we've developed some protocols to help make that transition easier for folks. Again, that would be a lecture for a different day, but we've done that successfully in many people. And so we have a fair percent of folks who've been on both buprenorphine at one time and Vivitrol at another time. And so we can ask them how they felt on the various medications. But you have to be careful when you switch from buprenorphine to naltrexone because you can precipitate withdrawal.
Dalmatina asks, would you support naltrexone suspension in a therapeutic community or sober support living environment that is equipped to provide medication and therapeutic services?
Yeah, I think that's a great idea. And keep in mind, for people who have an abstinence-oriented philosophy, naltrexone fits in very well with that kind of program. Just like when we had the alcohol treatment unit and we're using naltrexone to help our patients with alcohol use disorders, that was an abstinence-oriented program. That's why we got the patients who are addicted to cocaine, because we also did abstinence-oriented treatment for that group. So it fits in very well with the philosophy of abstinence. So long the trick is in sober living housing or therapeutic communities to get people to be consistent with taking their medicine, and you probably would have better luck with getting people to adhere to treatment if they're living in a therapeutic community.
So Samatina commented and said, exactly, because they despise methadone, and I find it hard to place clients in these environments of care while in methadone maintenance treatment. So that is true. We find it, I think that's fairly common in a bunch of different regions of the United States, and it's difficult to find. So we're living communities that take people that are on maintenance medications such as buprenorphine or methadone. It is very difficult.
Yeah, I think buprenorphine is a little bit more controversial, but I've had patients who I've put on buprenorphine who got kicked out of group therapy because they're on buprenorphine.
Yeah.
So I'm not in favor of that. I'm more, trying to be tolerant of all approaches to treatment. I don't think there's one size that fits all, but I do think Vivitrol has been underutilized and certainly fits in with the philosophy of abstinence-oriented care. Any other questions?
I had one come in. We'll go ahead and make this the last question. Again, it's from Mary Coy. I'll go ahead and post it in the all chat so you can see it.
Is this from Taylor?
No, it should be from Fata On Demand.
Okay.
When I send it in the chat. Mary Coy sent it to me directly.
Sure.
Here we go. I'll just read it out loud.
Okay.
Once started seems to be a severe challenge to overcome the addiction. Have the thoughts of using some type of hypnosis been considered to remove this memory? I know this is drastic, but I worked in the jail and the relapse rate is very high.
Well, we haven't used hypnosis as a way of getting rid of people's memories, but let me tell you my experience with using Vivitrol in patients. And again, this doesn't necessarily come across in the data that I presented, but I'm going to tell you my clinical experience. Again, I've seen patients who've been on buprenorphine for years. I've had patients on Vivitrol for years. And from my perspective, there's a difference in outcome between those two groups. The patients who've been on buprenorphine, they still see themselves as addicted, as a drug addict. So they'll say, I'm not doing my addiction now, but I know that that's always something that's in the back of my mind. My patients on Vivitrol, it's interesting. They come in and they see me, and their concerns are they're not getting along with their spouse, or they're fighting with their boss. It's like the addiction was an old part of their lives that's not even present anymore. They're not even thinking about it. And then sometimes they'll go in and talk with groups about their experience with Vivitrol, and one of my patients was telling me that he's lost all his street cred, that people don't buy it anymore because he's doing so well in his life. He's successfully working, he has good relationships, and he says, I used to be a dealer, and people don't believe it anymore. I know he was a dealer because I had patients in my waiting room who said, this was my dealer. So I know he's telling the truth. He was arrested, he went undercover to avoid prison time, and when you look at him now, he looks like an entirely different person. So even the people who have been absent for a period of time and do it through abstinence-oriented programs, they still have periods where they're white-knuckling it. They still think about the fact that they used to have a problem with addiction, even if they don't currently, and they still say it's just one day away. And again, my experience with Vivitrol is it becomes something that they don't even think about anymore. Now, there may be some pharmacologic reasons for this effect, but there's pretty good experimental data that when a person is in a situation where the body expects that it's going to get drugs, so maybe someone who's an alcoholic goes to a party and everyone else is drinking, maybe people go to a meeting and people are talking about injecting drugs. I remember when I worked at the VA during the AIDS epidemic, there was a poster of a person who had these big juicy veins and he was injecting with a needle, and it said, don't use dirty needles. Well, my patients who saw the poster all started craving opiates, and they said, oh my God, look at that juicy vein, I want to use opiates. And so when your body expects, when it sees something that reminds them of using drugs, it stimulates craving for it. Now, data with Vivitrol or naltrexone blocks that. And there's actually experimental data where they looked at brain scans, and when someone is craving opiates or alcohol, a part of the brain lights up and correlates with their craving. When you're on naltrexone, that part of the brain doesn't even light up. And so when it comes to memories, it doesn't block your memory of it, but it blocks the affective component to it, the emotional response to it, where you just don't care anymore. So that's why I think Vivitrol long-term may be a little bit better outcome for many people.
And Mark, I know you said that was the last question, but there's one more I see from Taylor that I think is really important to address.
Yeah, go ahead.
That says, I've had a couple of participants say the fourth week of Vivitrol is hard for them as they experience strong cravings all of a sudden. Has this been anyone else's experience? And I would say wholeheartedly, yes, from our perspective, we do see that a lot.
Yes, I agree with it, that for some folks, Vivitrol is only like a 3-week medicine. And I've had, as you can imagine, some of my patients have tested this theory out. So I've had patients who tried getting high after 1 week of Vivitrol, no luck, even after a bundle or two. 2 weeks, no luck. 3 weeks, maybe a little bit of a hint, but at 4 weeks, they can begin to feel the effects of opiates. So for some people, it's more of an every 3-week medicine, not every 4 weeks. And so for those folks, I give them shots every 3 weeks. And I have to say that parenthetically, usually I recommend people get shots every 3 weeks. Part of the reason is because for some people it wears off after 3 weeks, but there's another reason, and that is sometimes my patients come up with problems why they can't come in and get their shot at week 4.
Mm-hmm.
So I want to have the flexibility that they can come in the next week and still be covered.
Mm-hmm.
So we often recommend that people come in every 3 weeks to get their shot.
I think that's all of the questions. Sam,
Perfect.
Comments thanking us, since that was very kind. Thank you for attending.
Yes, thank you.
I'd like to thank Dr. Volpicelli, and I'd like to thank you, Lauren. Coming in relief there was fabulous. Way to roll with the punches.
Yeah, no problem.
I'm going to regain control of the presentation and conclude.
Excellent. Thank you.
Thank you.
Please note a couple of items of business before we conclude today. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CEs or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for FLA licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to an evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger@WebEx. Evaluations will close midnight on Thursday, November 14th. If you do not receive this email, simply go to fada.org, look at the calendar on the right-hand side, and look for today's event. Click on that link, and there will be a Take Survey button there for you to view. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Office of the State Court Administrator, for funding today's education. Have a great rest of your day, and please hold for the evaluation.